From Microbe TV, this is Infectious Disease Puscast, episode 57, recorded on June 19th, 2024. Hello, everyone. I'm Daniel Griffin, and unfortunately, Sara Dong is out sick this week. But I am assured it is a minor upper respiratory pharyngeal malady, so she will be back with us next episode. Without that, no banter. It's just me. So we will jump right into our Puscast. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. Sara actually put a few of these articles in there, so I'll make sure to give her some credit. And now on to the literature, shall we? Well, we are going to start with viral. Remember to listen to TWIV, This Week in Virology, both the clinical updates and the deep dives. And we're going to start off with the first article that Sara found in JID, Cytomegalovirus Antiviral Resistance Among Participants in the Phase 3 trial of letermovir versus valganciclovir prophylaxis in kidney transplant recipients. So these are the results of a Phase 3 trial where letermovir was compared to valganciclovir for CMV disease prophylaxis. These are going to be CMV seronegative kidney transplant recipients who received a kidney from a CMV seropositive donor. While we first learned that letermovir was non-inferior to valganciclovir in this trial, they then do a resistance analysis where the CMV DNA was sequenced for presence of known letermovir and valganciclovir resistance-associated amino acid substitutions, RASes. So we need another multi-letter acronym there. And these are encoded by the CMV gene regions, UL51, UL56, UL89, UL54, UL97, and the prevalence of GB, UL55 genotypes, GB1 through GB5. Now, I must say, this just reminds me of how I get a little annoyed when they put this on our board exams and they have some multi-level question, and then it comes down to like knowing, UL97 is the right answer. This is like the days of when we used to have to memorize which chromosome the Huntington's disease genetic issue was on. Now, as we have more and more CMV gene regions, will they make us memorize every single one of these? Okay. Well, we read that 84 of the 292 participants in the letermovir and 93 of the 297 in the valganciclovir group had evaluable data for one or more gene targets. So the letermovir RASes, right? Those are those resistance-associated amino acid substitutions. So letermovir RASes were not detected in participants who received letermovir prophylaxis. However, 3 actually had valganciclovir resistance genes, or resistance-associated amino acid substitutions, which is really the right way to say that. 12 participants in the valganciclovir group had valganciclovir RASes, and 1 who did not receive letermovir during the trial also had letermovir RASes. This is a UL56. So sort of interesting that's even out there. All but 1 participant responded to valganciclovir treatment irrespective of breakthrough CMV DNA-emia, or frequency of RASes. GB1 was the most frequent genotype across all participants and subgroups. So what do we have to say about this? So first, non-inferiority, that's great. So I was not surprised that we would see more resistance for a drug that we have been using for a longer period of time. Also, as mentioned, nice to see this non-inferiority. But why switch and have to learn all about this newer drug? Well, letermovir, brand name Previmiss is an interesting first-in-class drug that's a viral terminase inhibitor. It specifically inhibits the CMV viral terminase complex, which is encoded by the CMV genes, UL56, UL51, UL89. I don't expect you to remember that. Other people might. And this inhibition has the effect of preventing the cleavage of the CMV DNA concatenames. So you end up with these long uncleaved DNA segments, non-infectious viral particles. Now, what about cost? I looked this up on GoodRx. The average cost of 28 tablets of 480 milligrams of Previmiss or letermovir is, with this wonderful coupon, $7,295, which is apparently 10% off that retail price of over $8,000 for those 28 tablets. So pretty expensive stuff we've got here. And it is a challenge, right? This is one of these issues. We always complain we don't have enough new drugs in the pipeline. And then when we get them, then we complain that they're too expensive. And then we don't use them. And then the drug company says, why do we even bother? So really a huge challenge and something we need to think a little better about how to address. All right, well, let me jump in here with the article, Prevalence and Risk Factors of Cytomegalovirus Reactivation in Critically Ill Patients with COVID-19 Pneumonia, published in PLOS One. So these are the results of a retrospective cohort study conducted among adult patients who were admitted to ICU and screened for quantitative real-time PCR for CMV viral load in a tertiary care hospital during the third wave of the COVID-19 outbreak in Thailand. A total of 185 patients were included, 133 patients, 71.9% in the non-CMV group, 52 patients or 28.1% in the CMV group. We have a mean age of 64.7, about half of them males, 54.6%. Now, the CMV group had received a significantly higher median cumulative dose of corticosteroids than in the non-CMV group. And these numbers are actually pretty big. You ready for this? 301 versus 177 milligrams of dexamethasone. I'm just thinking about that. What is that, like 6 days of so much? Oh my gosh, this is a lot of dexamethasone. Now, other modalities of treatments for COVID-19, including antiviral drugs, anti-cytokine drugs, and hemoperfusion, were not different between the two groups. The 90-day mortality for all patients was 29.1%, with the significant difference between the CMV group and the non-CMV group. So 42% versus 24%. Good p-value less than 0.05. Median length of stay was longer in the CMV group than the non-CMV group. The CMV group had detectable CMV DNA load with a median of 4,977 IU per ml and 24,570, and that's plasma BAL fluid, respectively. Now, one of the things I will say here, so they're going to tell us that really it was dexamethasone that had this association, but I do worry, is the dexamethasone a marker for a different severity in these folks? Like, why are they getting so much dexamethasone? But mechanistically, it also makes sense to think that dexamethasone may also be causative in this situation. All right, Sara's article in Open Forum Infectious Disease. So Fasbuvir, off-label treatment of yellow fever patients during an outbreak in Brazil, 2018, a cohort study. So a small study, 21 patients with laboratory-confirmed yellow fever and hospitalized at Eduardo de Menezes Hospital, Brazil, who were treated with Sofosbuvir, a drug approved for hepatitis C. So patients received a daily dose of 400 milligrams Sofosbuvir from 4 to 10 days post-symptom onset. The yellow fever viral load, we all know that that's actually not viral load, but comparisons were made between treated and non-treated patients who either survived or died. The genomic viral load for the treated group steadily decreased after 7 days post-symptom onset, suggesting that Sofosbuvir did reduce the yellow fever virus nucleic acid amplification values. The authors suggested that this study underscores the urgent need for yellow fever antiviral therapies, advocating for randomized clinical trials to further explore sofosbuvir's role in YF treatment. Well, thinking about this, right? Like, how does this work? What's the story? So just to give people a little mechanistic nod here, as a prodrug nucleotide analog, sofosbuvir is metabolized into its active form as the antiviral agent, which acts as a defective substrate for NS5B, that's non-structural protein 5B, which is an RNA-dependent RNA polymerase. All right, we will move into bacterial. Be sure to listen to This Week in Microbiology. We'll leave in a link. The article, Preventing New Gram-Negative Resistance Through Beta-Lactam De-Escalation in Hospitalized Patients with Sepsis, a retrospective cohort study published in CID. Now, I think this is a really important fundamental concept paper, right? So we have a patient that gets admitted with some sort of infection, and then we get the cultures back where we're delighted to see that the isolate is, if sensitive, some narrow spectrum antibiotic. We're taught to carefully, I'm not going to say de-escalate, carefully optimize therapy to the narrowest spectrum antibiotics that is appropriate for the site of infection. But something seems to happen to my dismay. The patient's doing so well on that Zosyn, that piperacillin tazobactam extended spectrum anti-pseudomonal antibiotic, coupled with some unnecessary vanco. So why don't we just keep going with that? And then at time of discharge, even when we might perhaps complete the appropriate course, everyone gets sent out on that high-dose Vantin stuff. Is the teaching wrong, or is the practice wrong? In this retrospective cohort study, patients with sepsis were treated with at least 3 consecutive days of beta-lactam antibiotics, the first 2 days of which were with a broad-spectrum beta-lactam agent, were enrolled. Patients were grouped into 3 categories. 1, de-escalation of beta-lactam spectrum score. 2, no change. And then 3, escalation of beta-lactam. The primary outcome was the isolation of a new drug-resistant gram-negative bacteria from a clinical culture within 60 days of cohort entry. So are we growing up those MDRs, those multi-drug-resistant organisms? Fine-grained proportional hazards regression modeling while accounting for in-hospital death as a competing risk was performed. And I am delighted that they are using the Fine and Gray's model here rather than that Cox method that overestimates hazards. So I'll leave in a link to a nice Columbia paper on competing risk analysis, and prepare for angry statisticians to email with heated opprobrium. I will comment, whenever I mention statistics, there's always some person who, feels that I'm oversimplifying. But anyway, 644 patients of the 7,742, so 8.3%, developed new gram-negative resistance. It's pretty high, 8.3%. The median time to resistance was 23.7 days. The lowest incidence rate was observed in the de-escalated group, right? Statistically significant reductions in the development of new gram-negative resistance were associated with beta-lactam de-escalation compared to no change. So about a 41% reduction in the risk of creating an antimicrobial resistant organism and hastening our arrival in the antimicrobial resistant apocalyptic world. So the teaching is right, the practice appears wrong. So please optimize those antibiotics when possible. All right, so Sara put this one in. I kind of highlighted it with highlight and discuss, maybe compare with the meta-analysis below. Well, in JAMA, we have the article, Continuous versus Intermittent Beta-Lactam Antibiotic Infusions in Critically Ill Patients with Sepsis, the BLING-3 randomized clinical trial. So here we have the results of an international open-label randomized clinical trial conducted in 104 ICUs, Australia, Belgium, France, Malaysia, New Zealand, Sweden, and the UK, to evaluate whether continuous or intermittent infusion of a beta-lactam antibiotic, piperacillin tazobactam or meropenem, results in decreased all-cause mortality at 90 days in critically ill patients with sepsis. So eligible patients were randomized to receive an equivalent 24-hour dose of a beta-lactam antibiotic by either continuous or intermittent infusion for a clinician-determined duration of treatment or until ICU discharge, whichever occurred first. The primary outcome was all-cause mortality within 90 days after randomization. Secondary outcomes were clinical cure up to 14 days after randomization, new acquisition, colonization, or infection with a multi-resistant organism, or C. diff, up to 14 days after randomization, ICU mortality, and in-hospital mortality. Now, within 90 days, 24.9% assigned to receive continuous infusion had died, 26.8% assigned to intermittent infusion had died. So 0.91 there for our odds ratio, but at overlapping confidence interval, p-value only 0.08. Clinical cure was higher in the continuous versus the intermittent infusion group. It was 55.7 versus 50%. Absolute difference, 5.7%. Now, the other secondary outcomes were not statistically different. So we're seeing here, didn't really seem to get it, and I know the headlines are sort of saying that. But remember, this is one study, didn't quite reach statistical significance. We're seeing a trend almost reached, so a p-value of 0.08. So there's an 8% chance that this is just due to chance, opposed to a 92% chance that there actually is something here. So what about all the other studies out there? And fortunately, we got the article, Prolonged versus Intermittent Infusions of Beta-lactam Antibiotics in Adults with Sepsis or Septic Shock, a systematic review and meta-analysis published in JAMA. So yes, here these investigators performed a systematic review and meta-analysis to determine whether prolonged beta-lactam antibiotic infusions were associated with a reduced risk of death in critically ill adults with sepsis or septic shock compared with intermittent infusions. From 18 eligible randomized clinical trials that included 9,108 critically ill adults with sepsis or septic shock, the pooled estimated risk rate for all-cause 90-day mortality for prolonged infusions of beta-lactam antibiotics compared with intermittent infusions was 0.86. So we're actually seeing a credible 14% reduction here, with a 99.1% posterior probability that prolonged infusions were associated with lower 90-day mortality. 99.1%, that's an A on most people's exams, maybe even an A+. Prolonged infusion of beta-lactam antibiotics was associated with a reduced risk of ICU mortality, risk ratio 0.84, and an increase in clinical cure. All right, so we have one study that didn't quite get there, but putting it all together, I think the preponderance of evidence is favoring these extended infusions. All right, Sara put in the article from JAMA Network Open, Phoenix Sepsis Score and Risk of Attributable Mortality in Children with Cancer. So we get a little background. We read that children receiving treatment for cancer are at high risk of sepsis-related death. I think our listeners are all familiar. Now, in patients with sepsis, identifying those at greatest mortality risk can help target interventions, research, and counseling. However, general pediatric sepsis scoring systems tend to perform poorly in children with cancer in high-income countries. So, the authors suggest this might be due to differences in clinical presentation or pathways to attributable death, maybe different scoring systems. So here, the newly developed Phoenix Sepsis Score, which was developed from 218,839 suspected infection episodes, is something recommended for all pediatric populations. However, children with cancer may have pre-existing organ dysfunction affecting score performance. Pediatric oncology subgroup analysis are unpublished, and the score has actually not been validated in pediatric oncology yet. But here, the investigators use an existing retrospective cohort to evaluate the Phoenix Sepsis Score in children receiving treatment for cancer admitted to the ICU with suspected infection. They reported that in this prognostic study. The Phoenix sepsis score was associated with mortality and prolonged ICU stay and numerically outperformed existing scores for attributable mortality. So it looks like it may work in this population as well. Now, Sara grabbed this one, but her not being here, I'm excited because I was all excited to discuss this, so I get the chance. In emerging infectious diseases, we have the article, Newly Recognized Spotted Fever Group Rickettsia as Cause of Severe Rocky Mountain Spotted Fever-like Illness, Northern California, USA. We read here that the incidence of spotted fever group rickettsiosis, SFGs, in the United States has tripled since 2010. The lack of species-specific confirmatory testing means that we don't really know which of the spotted fever group rickettsia is really making up this increase. So here the authors report a newly recognized rickettsial pathogen. Are you ready for this? Rickettsia species CA6269 as the cause of severe Rocky Mountain spotted fever-like illness in 2 case patients residing in Northern California. Multi-locus sequence typing supported the recognition of this pathogen as a novel rickettsia genotype, mostly closely related to R. rickettsii. Cross-reactivity observed for an established molecular diagnostic test indicated that Rickettsia species CA6269 might be misidentified as R. rickettsii. So they develop a Rickettsia species CA6269 specific real-time PCR to help resolve this diagnostic challenge and better characterize the spectrum of clinical disease and ecological epidemiology of this pathogen. Ecological epidemiology of this pathogen. All right. Now, why do we care? I mean, I guess we care for a couple of reasons. It's important to know if we start seeing something odd here, is it that something is changing about this particular subspecies of Rickettsia? So sort of applaud them for finding this. All right, and Sara also put in transplant infectious disease, the American Association of Tissue Banks Tissue Donor Screening for Mycobacterium tuberculosis recommended criteria and literature review. Now, we read that after 2 multi-state outbreaks of allograft tissue transmitted tuberculosis due to what kind of allograft tissue? Viable bone. Evidence-based donor screening criteria were developed to decrease the risk of transmission to recipients. So exclusionary criteria, commentary, and references supporting the criteria were provided in this. This is based on a literature search and expert opinion. I hate expert opinion. I was joking today on rounds about the Delphi consensus, where a bunch of people get together and they have uneducated conjectures and recommendations, but both exposure and reactivation risk factors were considered, either for absolute exclusion or for exclusion in combination with multiple risk factors. A criteria subset was devised for tissues containing viable cells. Risk factors for consideration included exposure, so geographic birth and residence, travel, homelessness, incarceration, healthcare, workplace, and reactivation, kidney disease, liver disease, history of transplantation, immunosuppressed medications, and age. They conclude by saying that donor screening criteria represent minimal criteria for exclusion, but do not completely exclude all possible donor TB risks. And I have to say, you really got to get that accurate history. We had a lady getting admitted to the academic center where I'm currently hanging out. She went through, I've never left the country, no travel. Except for that time I spent in Paraguay, where, oh my gosh, everyone has tuberculosis down there and was coughing all over me. But don't you worry, I didn't get any of that TB. So she says. Okay, moving on to fungal. Be sure to watch The Last of Us, and I'll leave in a link. The article, Potential Sexual Transmission of Tinea pubogenitalis from TMV2, was recently published in JAMA Dermatology. So for starters, what a horrible name. Am I pronouncing this correctly? Pubogenitalis? Well, for background, Tinea genitalis pubogenitalis is a rare manifestation of dermatophytosis affecting the genitals and pubic region. In the last decade, male genital dermatophytoses have been increasingly reported in India, just when I wanted to go see the Taj Mahal, corresponding to the emergence of Trichophyton indontanea. In the introduction of this paper, the authors tell us that climate, hygiene, and bathing practices likely contribute to genital dermatophytoses in India, which is also driven by, you ready? Inappropriate use of topical steroids. There was a recent report that highlighted the potential for sexual contact to transmit T. indontanea. I will leave in a link to that paper, Potential Sexual Transmission of Antifungal Resistant Trichophyton indontanea, published in Emerging Infectious Disease. Well, similarly, Tinea genitalis has increasingly been reported in Europe, attributed to the emerging dermatophyte T. mentogrophytes, which may spread via sexual contact. Here, the authors described a patient with T. mentogrophytes, internal transcribed spacer ITS genotype 7, VII, TMVII, resulting in tinea genitalis, glutealis, and corpus to highlight risk factors, diagnosis, and treatment. I hope we're getting a little bit maybe of getting this on people's radar, but here we read about a male in his 30s referred with a scaly erythematous eruption in the inguinal region, genitalia, legs, arms, and back. We know that he traveled to Europe, England, and Greece, and within the U.S., apparently California, prior to developing skin lesions. He reported multiple male sexual partners while traveling, none with a similar infection, and visiting a sauna 2 months prior to developing skin lesions. He reported shaving and waxing the pubic region and denied pet exposure. The patient reported taking pre-exposure prophylaxis but did not have HIV or immunocompromising conditions and denied tinea unguium. Prior to referral, a skin biopsy from the right thigh demonstrated dermatophytoses, and he was treated with 150 milligrams fluconazole weekly for 4 weeks with no response. On referral, a fungal culture grew in isolate conventionally identified as T. interdigitale. Sequencing of the ITS region of the ribosomal gene at the Wadsworth Center, New York State Department of Health, hey, that's right here, confirmed TM7. He was treated with 6 weeks of terbinafine, 250 milligrams daily with improvement. But due to persistent infection, he was transitioned to itraconazole, 200 milligrams daily with further improvement. So, all right, that's a lot. Take-home points. For starters, I will say the rash was very characteristically fungal. So if you want to look at some of the photos in this open access paper, I pasted them in here, but this is open access. Now, providers should be aware that TM7 infections may transmit locally. Prompt treatment may reduce the risk for scarring and transmission, right? So this can scar and you can spread it to other people. Routine culture cannot distinguish T. mentogrophytes from the closely related T. interdigitale. Clues to diagnosis include the tinea genitalis, which may be inflammatory or abscess forming, recent sexual intercourse, prolonged treatment may be necessary. So that's kind of why this is sort of coming to attention. When TM7 is suspected or diagnosed, sexual partners should be evaluated and the patient screened for other sexually transmitted infections. Okay. Now, this might seem silly, but we're not just covered in fungus, but instead we catch fungus from other people, right? I mean, a lot of stuff like, oh, it's part of your microbiome, it lives on your skin, it gets this opportunity. But remember those issues with walking around barefoot at the gym and those silly people with flip-flops? Oh, yes, I was one of those silly people and still am one of those silly people with the flip-flops. The article, Household Transmission of Tinea Infections, Analysis of a Large Commercial Health Insurance Claims Database, United States 2021, was published in Open Forum Infectious Disease. And here, using claims data, we read that among 207,914 multi-member households with a tinea case, a secondary case was diagnosed in another household member in 8.5%. Excluding same-day diagnoses, that was 20%. Median time from index case to first secondary case was 138 days. That's a lot. So just when folks come in and they've got a tinea infection and they ask, how did this happen? you might find the culprit in the same household. All right. Also concerning to read the article, drug-resistant oral candidiasis in patients with HIV infection, a systematic review and meta-analysis published in BMC Infectious Disease. So this study looked at the increasing resistance to antifungal drugs for patients with oral candidiasis and HIV, and we read that resistance to the antifungal agents were as follows: ketoconazole, 25.5%, fluconazole, 24.8%, 5-FU, 22.9%, itraconazole, 20%, voriconazole, 20%, miconazole, 15%, clotrimazole, 13.4%, nystatin, down at 4.9%. So maybe start thinking a little bit more about that nystatin swish and swallow, maybe those clotrimazole troches, amphotericin B, 2.9%, and caspofungin was only 0.1%. So perhaps a little less of the fluconazole, a bit more of the nystatin swish and swallow. Okay. Parasitic, be sure to listen to This Week in Parasitism. I have to say, the last episode we recorded was just a blast. A buddy of mine, Mike, was on, who I met in prior visits to Scotland. So I will plug microbe.tv/TWIP. Now, here we have the article, Rapid and Comprehensive Screening for Urogenital and Gastrointestinal Schistosomiasis with Handheld Digital Microscopy Combined with Circulating Cathodic Antigen Testing. Okay, recently published in the American Journal of Tropical Medicine and Hygiene. Now, schistosomiasis is such a horrible disease, and perhaps the only thing worse is when it involves the urogenital area. Women describe this as feeling like they're being burned, having an open wound being touched. We really need to diagnose and treat this disease. So here we read that these investigators conducted a cross-sectional study where they evaluated the diagnostic operating characteristics of a converted mobile phone microscope, the schistoscope, catchy name, for the detection of schistosoma hematobium eggs, as determined by community-based field workers and expert microscopists, compared with field gold standard of light microscopy. And I've actually seen this, table sitting out there and, outside the hospital looking at the samples. Now, 365 urine samples were evaluated by conventional light microscopy with 13.4% positive for schistohematobium. Compared with light microscopy, the sensitivity of S. hematobium detection by field microscopists trained to use the schistoscope was, I'm going to say only 26.5%. So sensitivity of the schistoscope, only 26.5% in folks that were trained. Specificity was excellent, 98.4%. The sensitivity by expert microscopists using the schistoscope was 74%. So maybe if we get a little better training, we can get a better sensitivity. Specificity, 98.1%. The sensitivity rose to 96.1% and 100% when we got those egg counts up above 5 and 10 eggs per 10 mLs. I was a bit concerned by the low sensitivity for the low egg counts, but agree that such an approach may aid in streamlined schistosomiasis control and elimination initiatives. All right. We also have the article, Scorecard Approach to Eliminate Onchocerciasis in Venezuela, recently published, also American Journal of Tropical Medicine and Hygiene. And perhaps the biggest thing here is the reminder that in the Americas, onchocerciasis, river blindness, has been eliminated in, I'm going to say, only 11 of 13 endemic foci by mass administration of ivermectin, but we still have river blindness in South America. The remaining at-risk population resides in a contiguous cross-border transmission zone located in the Amazon jungle in northwest Brazil and southern Venezuela, known as the Yanomami Focus Area. And here they show how this scorecard approach helps with planning, monitoring, maximizing programmatic efficiency. It helps with the challenges in this endemic area, its remoteness, its large areas of territory, the semi-nomadic nature of the Yanomami people, and their continuous cross-border movements by identifying communities at high, medium, and low priority. The results show that prioritizing communities at risk and with greatest needs increases the feasibility of interrupting the transmission of onchocerciasis by, you ready, 2025 in the last endemic foci in the Americas. That's coming right up, fingers crossed. All right, just a couple to wrap it up here in the miscellaneous. The article, Association Between Antibiotic Receipt and Provider Rating Within a National Telemedicine Practice, was recently published in Open Forum Infectious Disease. Oh my gosh, will I get a better Yelp review if I give you unnecessary antibiotics? I'm a bit worried about this. These are the results of a retrospective cohort study that estimated the association between prescription receipt and provider 5-star rating for adult visits with upper respiratory infections in a national telemedicine practice with active antibiotic stewardship initiative. Apparently, the odds of a 5-star rating were higher for visits with an antibiotic or non-antibiotic prescription, right? So give them something, and longer visits. So let us look a little deeper than the headline in the abstract. So they go ahead and they look at 68,607 visits among 298 providers, of which 47,695 had a provider rating, 30.2% bronchitis, 9.8% of the URIs resulted in an antibiotic prescription. The average visit duration was 9.2 minutes, plus or minus 4.5. So, wow, some were as short as 5, some were as long as 13 or so. A little increase in likelihood of getting that 5-star rating with giving patients a little more time. Okay, so unnecessary antibiotics, a little extra time, maybe a little extra time. Over 95% of the visits actually had a 5-star rating. So 92.4% with no script, 95.6 with a non-antibiotic script, 97.7 with an antibiotic script. So really not as different as we might seem, right? So if you say, listen, I don't think an antibiotic is appropriate, you're still 92% of the time going to get a 5-star rating. If you say, listen, I don't think an antibiotic, but we're going to do something else, still about 96%, you're going to get that 5-star rating. And if you throw an antibiotic, you can maybe get up to 97.7. So maybe not as much encouragement to do unnecessary antibiotics to get that 5-star review. All right, in perfusion, the last one Sara picked, infectious diseases and infection control prevention strategies in adults and pediatric populations on ECMO. Now, I agree with the authors here when they suggest that as survival after ECMO improves and use of ECMO support increases in both pediatric and adult population, there's a need to focus on both the morbidities and complications associated with ECMO and how to manage and prevent these. It's not just about survival. Infectious complications during ECMO often have a significant clinical impact. You can end up with increased morbidity, actually can also increase mortality. This is a nice review article where the authors discuss the prevention, management, challenges, and differences of infectious complications in adult and pediatric patients receiving ECMO support. It is unfortunately behind a paywall. All right, that brings us to the end of this Puscast. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire. You can find the Infectious Disease Puscast at Apple Podcasts or grab it with your favorite podcatcher or go to microbe.tv/Puscast. We love to get your questions, comments, and paper suggestions, so keep sending them to puscast@microbe.tv. If you like what we do or you just want us to keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute. Just click on that contribute button, or Parasites Without Borders at parasiteswithoutborders.com and click on our donate button. Well, unfortunately, Sara's not here, but you can find her at swindong at Febrile Podcast or febrilpodcast.com. Wishing her a speedy recovery. I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye. Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.